Hello, everyone, and welcome to another episode of the Clinical Podcast Series. My name is Andrew Pucker. I am the Executive Director of Clinical Medical Sciences at Lexitas Pharma Services, and today I'm joined with Kaleb Abbott. Kaleb, could you please introduce yourself?
I'm an optometrist and assistant professor at the University of Colorado School of Medicine. I practice in our dry eye clinic in our Center for Ocular Inflammation. And with that comes a lot of complex ocular surface disease and a whole lot of referrals for neuropathic ocular pain as well.
Cool. Well, today we're actually live at Academy, and we're going to talk about one of what I think is the coolest posters at the meeting, which is, of course, by Kaleb here. And it's called Varenicline as a Potential Therapy for Neuropathic Ocular Pain Associated with Trigeminal Neuralgia. So could you just tell us a little about the topic and why you picked it?
Yeah, the purpose of doing this poster was to really present a case where intranasal varenicline was actually able to substantially improve both neuropathic ocular pain and facial pain in one of my patients that had severe trigeminal neuralgia. And I think this topic is important to optometrists because so many of our quote-unquote dry eye patients don't really have dry eye at all, but rather they're having ocular manifestations of another problem, perhaps a nerve abnormality that's really mimicking dry eye and causing dry eye type symptoms in our patients.
Yeah, I think that's a really hot topic now, which is partly why I picked it. So we have this talk of neurotrophic keratitis and patients with that, maybe just having like these really bad dry eye symptoms like early stage NK, so I think that diving into this case a little more could be helpful. So just tell us about the patient that you had in your clinic and kind of what they looked like in your chair.
Yeah, so this was a 62-year-old female that had a 14-year history of right-sided trigeminal neuralgia. So she had persistent pain of her right eye periorbitally, so kind of on the upper and lower eyelids, kind of along the face, and then on the top of her head as well. And this pain was quite severe for her. It would be as high as a 10 out of 10, but kind of on average was about an 8 out of 10. And she described the pain as a shooting or a stabbing pain that again affected only the right eye. She also had extreme photophobia to the point that she was having to turn down the computer brightness, and she even told me that when she went to restaurants, she was having to unscrew the light bulbs that were above the table because it was causing so much discomfort. And that's really consistent with something called photoallodynia. So allodynia is the concept that something is causing pain that shouldn't cause pain. And this is important for us to understand if we're treating neuropathic ocular pain. Then she also had extreme wind sensitivity and then tactile sensitivity as well. So you would, if she touched her face, it would cause a lot of pain. And then if she went outside and there was wind, it would cause excruciating pain. And that's consistent with something called hyperalgesia. So this is the concept that something that should induce a little bit of pain ends up inducing a lot of pain in these patients. And these are really two characteristics of a patient that has a neuropathic pain. But then when we went to do the exam, we noticed that she didn't have any meibomian gland dysfunction, no blepharitis. Her tear film was pretty stable. She had a tiny bit of corneal staining, but it was of both corneas. And overall, the signs were quite minimal, but her symptoms far outweighed those signs. And it was also important to know that she was having all this pain just on the right side, but the signs were equal between the eyes. So we ended up doing proparacaine testing with her. So this is trying to understand where the pain is coming from. So we numbed the eyes, and she reported 95% improvement in her light sensitivity and in her right eye pain. So this is consistent either with nociceptive pain, which would be more like dry eye, which we kind of ruled out, or it could be kind of neuropathic corneal pain.
So that's interesting. When I've thought of the proparacaine test, I've kind of thought about, like it numbs the eye, and then if it's an external environmental thing, the pain should kind of go away. But that doesn't sound like that's always the case.
Yeah, you have to you can use it to understand if it is neuropathic corneal pain really originating from the cornea, because you can actually numb those nerves. And then you can use it to tell whether or not it is further upstream, or even in the kind of the pain processing centers of the brain as well.
So you being at a major medical facility, had some additional tools. What did you do to figure this out? What kind of testing?
Yeah, because I'm at a university, we have access to confocal microscopy, which is essentially a tool that zooms 600x on the corneal nerves. So far greater magnification than you can see with the slit lamp, where you can't really see the corneal nerves much at all. So we zoomed in on the subbasal nerve plexus, that plexus of nerves kind of in the anterior 1/3 of the stroma. And the left eye's nerves looked completely normal. The right eye's nerves had decreased nerve density, which is consistent with neuropathic corneal pain, but then also had something called microneuromas. These are essentially severed nerves that are also enlarged and potentially also inflamed. And this is highly consistent with neuropathic corneal pain.
So for someone who hasn't really done confocal, is that something the machine just tells you, or do you just need to kind of know what the patterns look like before evaluating the pictures?
Yeah, you have to know what you're looking for. It's quite simple, kind of once you've read a few of these, but yeah, you just have to have the tools to actually look at it.
Cool. Well, that sounds like a great case. Are there any other things you want the audience to know about before we close out?
So in this case, her prior treatments for trigeminal neuralgia included like gamma knife procedures, microvascular decompression, pregabalin, gabapentin, and duloxetine. We started her originally just on a steroid taper with loteprednol to see if this improved her symptoms. It didn't. Then because she had changes to that subbasal nerve plexus, we ended up putting her on high concentration autologous serum eye drops, because there's evidence that using something to quiet inflammation like a steroid and high concentration serum drops over the course of maybe 6 to 12 months can actually improve pain in these patients. But 3 months later, she told us that this was cost prohibitive for her. So we were trying to find any options that we really could. So we ended up prescribing intranasal Varenicline off-label, kind of as a way to stimulate that trigeminal nerve. And what you're really trying to do here is work through the principles of gate control theory. So trigeminal nerve stimulators have been used for decades for trigeminal neuralgia, but not really for neuropathic ocular pain associated with trigeminal neuralgia. And so in chronic pain states, there's this theory that essentially the gates remain open and continuously are firing. But if you overstimulate those nerves, those gates will actually close. And when they close, you can decrease the pain that these patients are experiencing. So that was the theory of why we prescribed intranasal Varenicline. And she came back 3 months later. She reported that she had had 60 to 70% improvement, not just in her right eye pain, but in her facial pain as well. And then that remained stable at a 9-month follow-up when we saw her again. And her quality of life scores also improved dramatically with the ocular pain assessment survey.
So going into this, what odds did you put on this actually working? Because it's kind of out of the box, right?
So in general, treatments for neuropathic ocular pain, neuropathic corneal pain have a very low likelihood of working. This is one of the tools that we have in our toolbox potentially to try to help these patients, and it's hard to say what the odds are. I've had several patients that have had improvement with this, with their trigeminal neuralgia associated pain. I'm starting to find that you have to dose it more frequently though. It can't really be twice a day. It usually has to be 3 or 4 times a day. But it's at least something to try in these patients, because these are very difficult patients, and if you can get them any improvement, it's worth it.
That's cool. So first thing doesn't work, keep trying, right?
Exactly.
Cool. Well, with that, I'd like to thank you, Kaleb, for being here today.
Of course. Thanks for having me on.
And I'd like to thank you all for tuning into this episode of the Clinical Podcast Series. I'd like to ask you to like and subscribe to this channel, and of course, tell 10 friends about us. So with that, I hope to see you on another podcast soon. Thank you.